Hi everyone, I am Professor Sung-Go from the Department of Cancer Biomedical Science of the GCSP. Now I'm going to talk about cancer overview. This is the first lecture for cancer overview. So today I'm going to talk about thyroid cancer and stomach cancer. In this lecture you will learn about what is cancer, normal anatomy and physiology, definition and types, epidemiology, which means key statistics, etiology, which means causes, risk factors, and prevention, and symptoms and signs, diagnosis, staging, treatment, survival rates, and the early detection of common cancers. So today, I'm going to talk about the thyroid cancer and stomach cancer, and next week, we are going to cover colorectal cancer and lung cancer, and so on. This material you can refer to these materials for this lecture. American Cancer Society, this is the official sponsor, this is an official homepage for the American Cancer Society, and National Cancer Institute, and Korean National Cancer Information Center, which is operated by the National Cancer Center. First, what is cancer? Cancer is a term used for diseases in which abnormal cells divide without control and are able to invade other tissues. Cancer cells can spread to other parts of the body through the blood and lymph systems, which is called metastasis. Cancer is not just one disease, but many diseases. There are more than 100 different types of cancer. The figure 1 shows the normal cell versus cancer cell. All cancers begin in cells. Humans contain about 100 trillion cells. Cells grow and divide in a controlled way to produce more cells for keeping the body healthy. When cells become old or damaged, they die and are replaced with new cells. In figure 1, the upper part, you can see the normal cell division. If time goes by, the cell can be damaged, and if there is no repair, the cell should die, and also the cells suicide, which is also called apoptosis. However, sometimes this orderly process goes wrong. The genetic material, which is DNA, of a cell can become damaged or changed, producing mutations that affect normal cell growth and division. When this happens, cells do not die when they should, and new cells form when the body does not need them. The extra cells may form a mass of tissue, which is called a tumor. So on the lower part, you can see the process, the development of tumor. In this process, maybe there should be the process which is also called carcinogenesis. So maybe by some kind of carcinogens, this process can develop. So in here, as you can see, the cells do not die. So the uncontrolled growth can happen. And then if the number of cells is increasing, then you can see the tumor by seeing. And there are two types of tumors, benign and malignant. Not all tumors are cancerous. tumors can be benign or malignant. Benign tumors aren't cancerous. They can often be removed. Cells in benign tumors do not spread to other parts of the body, so these benign tumors are non-fatal. So these benign tumors cannot affect the mortality. But on the contrary, malignant tumors are cancerous. Cells in these tumors can invade nearby tissues and spread to other parts of the body. The spread of cancer from one part of the body to another is called metastasis. So malignant tumors are fatal. These malignant tumors are also called cancer. Some cancers do not form tumors. For example, leukemia is a cancer of the bone marrow and blood. There are more than 100 different types of cancer. Most cancers are named for the organ or type of cell in which they start. For example, cancer that begins in the colon is called colon cancer. Cancer that begins in melanocytes of the skin is called melanoma. The main categories of cancer are as follows. First, carcinoma. This is from the skin or in tissues that line or cover internal organs. For example, adenocarcinoma, basal cell carcinoma, squamous cell carcinoma, and transitional cell carcinoma. Sarcoma is from bone, cartilage, fat, muscle, blood vessels, or other connective or supportive tissue. And also, there is leukemia, which is from blood-forming tissue, such as the bone marrow, and it causes large numbers of abnormal cells to be produced and enter the blood. Lymphoma and myeloma. They are from the cells of the immune system. Lastly, there are central nervous system cancers. They are from the tissues of the brain and spinal cord. And I'm going to talk about cancer statistics. There are several terminology. First, incidence. This is the number of newly diagnosed cases during a specific time period. Mortality is the number of deaths during a specific time period. Prevalence means new and pre-existing cases for people alive on a certain date. Survival means the proportion of patients alive at some point subsequent to the diagnosis of their cancer. Lifetime risk is the probability of developing or dying of cancer. So please remember these terms: incidence, mortality, prevalence, survival, and lifetime risk. Cancer is a major cause of morbidity and mortality. And here, morbidity means having disease, and mortality, death. There are approximately 14 million new cases and 8 million cancer-related deaths in 2012 worldwide. Age standardized incidence and mortality rates of 182 and 102 per 100,000 people, respectively. For all cancers combined, excluding non-melanoma skin cancer, the highest incidence rates are associated with the high-income countries of North America and Western Europe. together with Japan, the Republic of Korea, Australia, and New Zealand. More than 60% of the world's cancer cases occur in Africa, Asia, and Central and South America, and these regions account for about 70% of the cancer deaths. According to the GLOBOCAN 2018, which was published by the IARC. IARC means the International Agency for Research on Cancer under the WHO. This data was published in the journal CA, a cancer journal for clinicians. Actually, this journal has the highest impact factor among all the scientific journals. At least the impact factor is about at least 200 over something, more than 200 something. And the GLOBOCAN is a project of the International Agency for Research on Cancer, IARC, which estimates cancer incidence and mortality by cancer site and sex using the best available data in each country and several methods of estimation. GLOBOCAN 2018 is an online database providing estimates of incidence and mortality in 185 countries for 36 types of cancer and for all cancer sites combined. GLOBOCAN 2018 is part of IARC's Global Cancer Observatory and is available online at Cancer Today with user-friendly facilities to produce maps and explore visualizations. An analysis of these results was published on 12 September in CA, a cancer journal for clinicians, in 2018. According to this data, in 2018, at the time, the total population was 7.6 billion people, and the number of new cases was 18 million, and the number of deaths was 9.5 million, and the number of prevalent cases was 43 million. And this figure shows the pie charts which presents the distribution of cases and deaths for the 10 most common cancers in 2018. A shows both sexes. B, males, and C, females. Here, this figure shows figure A, both sexes. As for incidence, the number one type of cancer is lung cancer, which accounts for 11.6% of all cancer types. Second one is breast, and then colorectal, prostate, stomach, liver, esophagus. As for mortality, there is similar but different. The highest mortality is observed in lung cancer patients, 18.4%. Second one is colorectal cancer. Third one is stomach. Fourth is liver, and breast, esophagus. This figure B shows the incidence and mortality for males. As for incidence, the first one is lung cancer, and second one is prostate, colorectal, stomach, liver. As for mortality, lung, liver, stomach, colorectal, and prostate cancer. This figure C shows the incidence and mortality for females. The highest incidence is breast cancer and also immortality. And second one, for instance, is colorectal, and then lung, cervical cancer, and thyroid. As for mortality, second one is lung cancer, third one is colorectal, and cervical cancer, and stomach cancer. Now I'm going to talk about cancer incidence in Korea. In Korea, this data is from December 23rd, 2019 from the Korea Central Cancer Registry, Ministry of Health and Welfare, and the National Cancer Center. The highest incidence in cancer is stomach cancer, about 13%. Second one is colorectal cancer. Third one is lung cancer, and the fourth is thyroid cancer. Cancer incidence by sex in Korea is like this. As for men, stomach is the highest incidence, and lung cancer has the second highest incidence. Third one is colorectal cancer and prostate cancer. But in women, the highest incidence is observed in breast cancer, and second one is thyroid. Third one is colorectal, and the fourth one is stomach cancer. This figure shows the lifetime risk of cancer. In Korea, if men live up to the age of 80, then the lifetime risk of cancer is 39.6%, which is about 40%, which means 2 in 5 people. And as for women, the average life expectancy at birth is 86. The lifetime risk of cancer until women live at the average life, then it is 33.8%, which is 1 in 3 women. Now I'm going to talk about thyroid cancer. This figure shows the anatomy of the thyroid gland. The thyroid gland is below the thyroid cartilage, which is also called Adam's apple, in the front part of the neck. This cannot be seen or felt in most people. Thyroid glands are butterfly-shaped with 2 lobes, right and left lobes, joined by a narrow isthmus. In the figure, you can see the thyroid gland, which consists of the right lobe and the left lobe and isthmus. This is below the thyroid cartilage. There are 2 main types of cells in the thyroid gland: follicular cells and C cells. Follicular cells make thyroid hormones T4 and T3 using iodine from the blood, which help regulate the person's metabolism. There are representative diseases regarding the amount of thyroid hormones. First one is hypothyroidism. Having too much thyroid hormone can cause a rapid or irregular heartbeat, trouble sleeping, nervousness, hunger, weight loss, and the feeling of being too warm. On the contrary, hypothyroidism In hypothyroidism, having too little hormone causes a person to slow down, feel tired, and gain weight. The thyroid-stimulating hormone, which is TSH, regulates the amount of thyroid hormone released by the thyroid. TSH is made by the pituitary gland at the base of the brain. Now, there are C cells, aka parafollicular cells. They make calcitonin, which is a hormone that helps control how the body uses calcium. This figure shows thyroid follicles filled with colloids and some parafollicular cells, C cells. Here, you can see the follicular cells, and inside there is colloid, and between follicular cells you can see parafollicular cells. There are some definitions regarding the thyroid mass. First, goiter, G-O-I-T-E-R. This means abnormally large thyroid gland. There are two types, diffuse goiter versus nodular goiter. Diffuse goiter means the whole gland is large, but the nodular goiter means the gland has one or more lumps or bumps in it. The goiter is usually not cancer. Then, what are the causes for goiter? Iodine deficiency, Graves' disease, which is the representative hyperthyroidism, and Hashimoto's disease, which is one of the representative hypothyroidism, and multinodular goiter, solitary thyroid nodules, thyroid cancer, pregnancy due to HCG, and inflammation. Nodules are lumps or bumps with the size of several millimeters to several centimeters. In 4 to 7% of the general population, there are we can see palpable nodules. Nodules can be found incidentally on ultrasonography in 19 to 67% of the population, according to the journal American Family Physicians in 2003. Most nodules are benign, but about 5 to 10% are cancerous. Most nodules are cysts with fluid or with a stored form of thyroid hormone called colloid. Solid nodules have little fluid or colloid, and they are more likely to be cancerous than are fluid-filled nodules. Nodules are mostly benign, and they require no treatment. There are several types of thyroid cancers. We can categorize them like this. First, development from follicular cells versus non-follicular cells. And also, we can classify them into like this: differentiated cancer versus non-differentiated cancers. In here, differentiated means they look like normal cells. Non-differentiated means they do not look very much like normal cells. They are the same as immature cells, poorly differentiated, or undifferentiated cells. Thyroid cancers developing from follicular cells are differentiated thyroid cancer. Among differentiated type thyroid cancer, there are 4 types. The first one is papillary cancer or papillary adenocarcinoma. The papillary cancer is about 80% of all thyroid cancers in general, but in Korea, the papillary cancer accounts for 97% of all thyroid cancers. Papillary cancer grows slowly and it has a good prognosis. Next one is follicular cancer. It is the next common type, up to 10%, but 1.4% in Korea. They are more common in countries with low consumption of iodine, relatively lower prognosis than that of papillary cancer. The third type is poorly differentiated thyroid cancer. This type of cancer is very rare and they have lower prognosis than that of differentiated thyroid cancer. And lastly, there is an undifferentiated thyroid cancer, which is also called anaplastic thyroid cancer. It is about 2% of all thyroid cancers, but in Korea, it is less than 1%. At the age of 60s, they have a bad prognosis. And also, there are thyroid cancers developing from non-follicular cells. For example, medullary cancer. It is about 4% of all thyroid cancers, less than 1% in Korea. It develops from the parafollicular cells, which are C cells. Sometimes they can spread to lymph nodes, the lungs, or liver, even before a thyroid nodule is discovered. Because this cancer does not absorb or take up radioactive iodine, the prognosis is not quite as good as that for differentiated thyroid cancer. Lymphoma is very uncommon. They develop from lymphocytes, especially B lymphocytes. This is the main cell type of the immune system. Also, from other organs, cancer can develop. For example, metastasis from breast cancer, lung cancer, renal cancer. This shows the epidemiology for thyroid cancer in the US. The 5 years relative survival rate for thyroid cancer is about 98%, which is almost near 100%. In Korea, the number of new cases is 26,000 out of 232,000 all new cancer cases, which accounts for 11%. And thyroid cancer is ranked 4th in Korea. And in men, the thyroid cancer is ranked 6th, but as for women, it is ranked 2nd. And the men versus women ratio is 0.3. The most frequent histologic type is papillary carcinoma, which is up to 97%. And then follicular carcinoma, medullary carcinoma, and anaplastic carcinoma. Then, what are the risk factors for thyroid cancer? First, what is a risk factor? A risk factor is anything that affects a person's chance of getting a disease, such as cancer. Different cancers have different risk factors. Some risk factors, like smoking, can be changed. Others, like a person's age or family history, cannot be changed. But risk factors don't tell us everything. Having a risk factor or even several risk factors does not mean that you will get the disease. And many people who get the disease may have few or no known risk factors. Even if a person with thyroid cancer has a risk factor, it is very hard to know how much that risk factor may have contributed to the cancer. There are several risk factors for thyroid cancer development. First, gender and age. For unclear reasons, thyroid cancers, like almost all diseases of the thyroid, occur about 3 times more often in women than in men. But in Korea, it's 5 times. Thyroid cancer can occur at any age, but the risk peaks earlier for women in their 40s or 50s when diagnosed than for men in their 60s or 70s. A diet low in iodine, this can be controversial, but follicular thyroid cancers are more common in areas of the world where people's diets are low in iodine. Radiation is a proven risk factor. Maybe the radiation is the only proven risk factor for the development of thyroid cancer. From certain medical treatments and radiation fallout from power plant accidents or nuclear weapons, radiation can affect the development of thyroid cancer. Radiation has a dose-dependent manner for the development of thyroid cancer, which means the risk increases with larger doses and with younger age at treatment. Before the 1960s, children were sometimes treated with low doses of radiation for things we wouldn't use radiation for now, like acne, fungus infections of the scalp, or enlarged tonsils or adenoids. Years later, they were found to have a higher risk of thyroid cancer. Radiation therapy in childhood for some cancers, such as lymphoma, Wilms tumor, and neuroblastoma, also increases risk. Then, how about imaging tests such as X-rays and CT scans? Generally, they are safe, but it is not clear how much they might raise the risk of thyroid cancer. For example, many times more common than normal in children who lived near Chernobyl, the site of a 1986 nuclear plant accident that exposed millions of people to radioactivity, as well as in adults. Also, hereditary conditions and family history can be the risk factors. Several inherited conditions have been linked to different types of thyroid cancer, as has family history. Still, most people who develop thyroid cancer do not have an inherited condition or a family history of the disease. Medullary thyroid cancer, especially familial medullary thyroid carcinoma, FMTC, is about 1 out of 3 medullary thyroid carcinomas. These can result from inheriting an abnormal gene. As per multiple endocrine neoplasia type 2, MEN2, means FMTC plus tumors of other endocrine glands. They are caused by mutations in a gene called RET gene, rearranged during transfection. There are 2 types, MEN2A and MEN2B. Usually, thyroid cancer patients have no symptom, but Mostly, neck mass can be instantly found by oneself, others, a physician through physical examination or thyroid ultrasound. There are several symptoms if the thyroid cancer progresses, and also signs. As you well know, symptoms mean subjective feelings or complaints perceived by the patient. On the contrary, signs means objective indications or evidence observed by the physician. So, these examples are symptoms and signs caused by thyroid cancer. A lump in the neck, sometimes growing quickly, swelling in the neck, pain in the front of the neck, which sometimes going up to the ears, hoarseness or other voice changes that do not go away, trouble swallowing, trouble breathing, a constant cough that is not due to a cold. But many of these symptoms can also be caused by non-cancerous conditions or even other cancers of the neck area. Lumps in the thyroid are common and are usually benign. Then how can we diagnose? Medical history and physical examination are very, very important. In these examinations, we need to consider symptoms and signs, family history, risk factors, and physical examination. And also, we can perform the thyroid function test. But usually, in thyroid cancer patients, the thyroid function test shows normal. The ultrasound is the first choice to determine if a thyroid nodule is solid or filled with fluid. Solid nodules are more likely to be cancerous. And also we can check the number and size of thyroid nodules. And how a nodule looks on ultrasound can sometimes suggest if it is likely to be a cancer, but ultrasound can tell for sure. And also we can conduct radioiodine scan. This helps determine if someone with a lump in the neck might have thyroid cancer by using a small amount of radioactive iodine, I-131. Hot nodules versus cold nodules. Usually hot nodules indicate non-cancerous conditions, but cold nodules indicate benign or cancerous nodules. But by itself, the radioiodine scan can't diagnose thyroid cancer. The most important diagnostic tool is the thyroid biopsy. The actual diagnosis of thyroid cancer is made with a biopsy, in which cells from the suspicious area are removed and looked at under a microscope. FNAB, this is the most important procedure for the diagnosis of thyroid cancer. Fine needle aspiration biopsy. The figure shows the ultrasound guided fine needle aspiration biopsy of thyroid. Here you can see the fine needle and also you can see the ultrasound probe. Under the skin you can see the thyroid gland including the thyroid cancer. So a thin hollow needle is inserted into the mass for sampling of cells several times. Then after being stained will be examined under a microscope. Cytology exam of aspirate, cell specimen evaluation, or histological biopsy, tissue specimen evaluation, FNAB. This is very safe and these are minor surgical procedures. And also we can conduct other examinations such as chest x-ray. We can see if especially follicular thyroid cancer has spread to lungs, and also CT scan, computed tomography scan, and MRI, magnetic resonance imaging scan, and also PET, positron emission tomography scan. And this slide shows the staging for thyroid cancer, which is called the TNM staging system. Staging is the process of finding out if and how far a cancer has spread. One of the most important factors in choosing treatment options and predicting patients' chance for cure is staging. Based on the results of the physical examination, biopsy, and examining tests, we can make a staging. The TNM system of the American Joint Committee on Cancer, AJCC. T indicates the size of the main primary tumor and whether it has grown into nearby areas. N means the extent of spread to nearby lymph nodes. Lymph nodes are bean-shaped collections of immune system cells to which cancers often spread first. Cells from thyroid cancers can travel to lymph nodes in the neck and chest areas. Lastly, M means whether the cancer has spread, metastasized to other organs of the body. The most common sites of spread of thyroid cancer are the lungs, the liver, and the bones. This figure shows T categories for thyroid. In the box, you can see the T categories for thyroid cancer. Tx means primary tumor cannot be assessed. T0 means no evidence of primary tumor. T1 means the tumor is 2 centimeters across or smaller and has not grown out of the thyroid. T2 means in size 2 centimeters to 4 centimeters and it has not grown out of the thyroid. If the size is more than 4 centimeters across, then it is classified as T3. And T4A, T4B. T4A is any size and it has grown extensively beyond the thyroid gland into nearby tissues of the neck, such as the larynx, trachea, esophagus, or the nerve to the larynx, also called moderately advanced disease. T4B means any size and it has grown either back toward the spine or into nearby large vessels. It is also called very advanced disease. N categories for thyroid cancer. NX means regional lymph nodes cannot be assessed. N0 means the cancer has not spread to nearby lymph nodes. N1 means spread to nearby lymph nodes. M categories for thyroid cancer. M0 means there is no distant metastasis. M1 means spread to other parts of the body, such as distant lymph nodes, internal organs, bones, etc. So, as a combination of TNM, we can make a final staging. This figure shows AJCC, UICC staging of thyroid cancer. Primary tumor T, regional lymph node N, distant metastasis M. By the combination of TNM, we can make the final staging. Stage 1, we can differentiate the staging into 2 categories by the age. patients less than 45 years old, as for papillary or follicular cancer, they are only stage 1 and 2. Any T, any N, any M0 is stage 1, but any T, any N, M1 is the stage 2. But if the patient is older than 45 years old, for papillary or follicular or medullary cancer at any age, we can classify into several stages. Stage 1, 2, 3, 4A, 4B, 4C. According to T1, T2, T3, or N0, M, T, N, M staging. Treatment. Doctors on thyroid cancer treatment team. There are several types of doctors. A surgeon is a doctor who uses surgery to treat cancers or other problems. An endocrinologist is a doctor who treats diseases in glands that secrete hormones. A radiation oncologist is a doctor who uses radiation to treat cancer. A medical oncologist is a doctor who uses chemotherapy and other medicines to treat cancer. And also, other specialists involve nurse practitioners, nurses, psychologists, social workers, rehabilitation specialists, and other health professionals. There are several treatment options by the type and stage of thyroid cancer. Surgery, radioactive iodine treatment, thyroid hormone therapy, external beam radiation therapy, chemotherapy, and targeted therapy. Usually, often, 2 or more of these are combined. Surgery. Okay, as per the first video of this week is here. So in the next video, I will talk about the remaining part for thyroid cancer and also stomach cancer. See you next time.